We are all
We
set.
are live.
Somalia copy. Check sound.
Live, sir.
Check Facebook.
Check. Checked.
Thank you. Dr. Maji, check sound.
Yeah, wait. Done. It's redirecting. We are on YouTube. Yeah. Tita, please start.
Thank you for confirmation.
A very good morning to all the dignitaries, distinguished guests, participants, and listeners present out here. On behalf of the organizing committee, I welcome you all to this second day of the first ever International E-Conference, Colloquium 2020, organized by Department of Pharmaceutical Technology, Chemistry and Biotechnology, JIS University. We are especially thankful to many dignitaries who are sharing their time with us in this event to render stimulation and appreciation to the international scientific community represented by many countries from all over the world. Moving on to our first plenary session of the day, I would now request Dr. Shundipan Bhattacharya to kindly introduce our first speaker of the day. Sir.
Yeah. Thanks so much, Preeta, for that introduction. And it's a pleasure to be here with you all. So without much further ado, let me introduce my esteemed colleague, Dr. Jason Horowitz. Dr. Horowitz is an assistant director of the Center for Health Outcomes and Pharmacoeconomics Research, which is also known as the Hope Center at the University of Arizona College of Pharmacy in the United States. And he's a former Pharma Foundation postdoctoral fellow in health outcomes research. His recent areas of research include assessing patient-reported outcomes of integrative medicine and the role of real-world evidence and comparative effectiveness research in healthcare decision-making. Dr. Horowitz has also taught research methods, data analysis, and statistics to Hope Center postgraduate fellows. And since 2009, he continues to teach health economics and outcomes research, or HEOR, to healthcare industry professionals at different Hope Center training programs that goes on around the whole year. Dr. Horowitz earned his PhD in educational psychology with clinical and scholarly expertise in assessment, intervention, and outcomes evaluation. And today he is going to talk about decision analysis. And I'm sure that you all are going to enjoy, and I would like to thank him personally to accept this invitation and taking the time during late at night in Tucson, Arizona, to talk to all of us. So, Dr. Horowitz, the floor is all yours. Thank you so much.
Thank you, Dr. Bhattacharya, and thank you all. Thank you, Dr. Amaji and Dr. Day and all of the organizers of this colloquia. And good morning to all of you, and thank you for joining me. It's such a great opportunity to be able to share this information with you. And I'm struck by how interdisciplinary the audience is and all of the departments, and I think this will appeal to everybody. So I'm going to share my screen now.
Professor Maji, copy.
मैंने तो नहीं किया पर मेरा नाम तो नहीं है इस लिस्ट में.
Professor Maji, copy.
Okay.
Somebody has already shared their.
Yeah, who is it? I cannot find.
Victor, copy. Victor, are you there?
So this one,
Sanjay Kumar Rawat, please stop. Please stop.
Sanjay Kumar Rawat, please stop sharing the screen, please.
Let me do one thing.
Just lock this screen sharing.
Yeah, now it's okay. Copy.
Okay. So my screen, you can see my screen?
Yes, sir.
Yes, sir.
Okay, great. Thank you. So we call this decision analysis. It's also called pharmacoeconomic modeling or decision tree analysis. And I think all of you may have received this worksheet and a copy of my slides. If you haven't, that's okay. We're going to spend the first half hour. This is like a workshop. We're going to spend the first half hour going through how to create a model and design a decision model. But if you don't have this worksheet or you are not able to print it, all you need is a blank piece of paper, a pencil, and a calculator. And the math is very simple, and I'll show you all about that. And there's no previous knowledge necessary for this. So let me introduce you first to what decision tree modeling is. They're powerful tools, and they're the cornerstone of all cost effectiveness analyses. And a model can allow you to organize large amounts of complex information, including costs and outcomes from various sources, to answer questions like, which is the most cost-effective treatment for a particular condition, for which patient or subgroups, which types of settings. And decision analyses can be used to compare any kinds of healthcare technologies, like medical devices, behavioral therapies, surgical procedures, even institutional policies or patient education programs. So, like I said, I think everyone in this audience can benefit from knowing a little bit more about decision modeling. And in fact, as I'll show you later, you probably do a lot of this in your own head when you compare different choices in your life too. So, but before I ask you to sketch out a decision tree, I want to point out some key features and then show you a couple examples. So all decision models start with a square decision node, and that leads to different comparators, and usually it's standard of care compared to the next best alternative. So not placebo. That's great for randomized control trials, but in cost effectiveness analyses, we're looking at real world comparisons between real alternatives. And in this case, we have two decisions: to vaccinate or not to vaccinate. And there are three health states. There's probability of three things happening from these choices. And so we indicate that with a chance node or a probability node, and it's that green circle. And the three outcomes are well, staying well, disease, or death. And this is a very simple illustration. Obviously, you can have things like surgery or different levels of severity and diseases, but we're just keeping this very simple. And the important thing is that the outcomes your tree has to include all relevant outcomes. If you're leaving anything off, it will not be a very accurate model. So the goal of all of this is to predict what's going to happen in real settings. The other thing is that the states have to be mutually exclusive, these health states, which means imagine one person goes through the tree, they can only be in one health state at a time. So it's mutually exclusive. Finally, we end with what's called a terminal node, these red triangles. That indicates the end of the tree. And you can keep adding branches and more branches. I'll show you examples. So we have 6 pathways in this very simple model. And another thing to note is that the top branch is the same in this case as the lower branch for the no vaccine, and that's called symmetric. And models do not have to be symmetric. For example, in this model comparing radiation therapy to no treatment, people have different outcomes that branch from radiation therapy versus no treatment. So it just depends on the disease area that you're looking at, what makes sense. And it's really helpful for people like me and Dr. Bhattacharjee to work with experts in those disease areas. We know the methods, but it's good to make sure that we're modeling the health states correctly. And here's another example, looking at patient-controlled analgesia versus epidural. And for epidural, there's complications where there isn't for the other group. Here's another example. You don't have to compare just 2 things. You can compare many things. And that's really where these decision models shine. Here we're comparing pain relief for osteoarthritis using 5 different medications. And after the acetaminophen arm, there's a lot going on there, as you can see, but they use that same branching structure for each of the other medications. So the authors call it clone 1, just as a shorthand. So all of this is reproduced here, 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 and here. Okay. Here's another example looking at immunosuppressants for kidney transplant recipients. Again, all of this is cloned right here. Okay, so I gave you some examples of some models. Oh, one thing I want to mention here, not all models that are published include these chance nodes and square nodes and terminal nodes. So just beware, but usually they do, like that one. Okay. Okay, now it's time for the workshop. So have your pencil ready, have your paper and your calculator ready. Let's say you've been asked to compare 2 medications. Drug A is the standard of care, and that's been on the market for 5 years. And drug B is a product that was recently approved for prescribing. So it's the new comparator, the new alternative. And you've gone through all of the literature and the randomized controlled trials, and you looked up costs, and you were able to extract all of this information and summarize it here in this table. So the first thing we're going to do is, using these data, we're going to sketch out what the model looks like, and we will label all of the branches. So for right now, ignore all of these numbers. And what do we know by looking at this? What do you see? How can we start sketching out this model? Well, we see that there are 2 drugs, right? Drug A and drug B. We see that there's a cure. So that's one of our parameters, cure or fail. And we could see that there's adverse events, yes or no. So very simple, we're keeping this simple here. So here I'll help to get you started. Right here's the decision node, which drug. And we've started to branch out, and we've labeled our branches drug A and drug B. And now we have a decision node, or I'm sorry, a chance node or a probability. Something is going to happen now after drug A. So if you have your worksheet, go ahead and write down just label what the next couple branches will look like. I'll give you a second. Did you write cure and fail? Maybe you wrote fail and cure. Maybe you wrote no AE or AE. That's fine. The order does not matter as long as we have the same labels and the same parameters. Mathematically, the model will work out the same. So AE again stands for adverse event. So this is how I've labeled it. Now you can go ahead and copy that. And to end the model, we need the terminal nodes. So does yours look like that? Maybe. What about drug B? Is this a symmetric model? Will drug B have the same branching structure? Yeah, it will. So does that make sense so far? So good, right? Now I mentioned that you can change you can have the labels in different places, but this is not just a coincidence here. Actually, best practice suggests that we should have the what we define as a treatment success in the topmost pathways. So for drug A, in this model, every model is different. We are defining treatment success as a cure without adverse events. A cure without adverse events. And we put those on the top. So when you look at a lot of different models, your eye will quickly go to the topmost pathways. And it could be more than one pathway that's a treatment success. Maybe with or without adverse events is still considered a success. Okay. Now we're going to focus on entering the data into this simple decision tree. All of this data that you collected. And we'll start here with the cure rate for drug A, which is 70% or 0.7. So what would be the failure rate for drug A? It's not on the table. 0.3, right? So that is called the complement. So 1 minus 0.7 is 0.3. So that's the complement. Now, our adverse event rate is 20%. So we put 0.2 there. So what would be the complement for no adverse event? 0.8, right? 0.8. So that's the complement. And what about for the failure rate? Is the adverse event the same in the fail arm? Yeah. So you still had to take drug A, and whether you failed or were cured, there's still a probability of an adverse event. So that would be the same here. Now it's your turn. So I'll give you a few seconds to enter in the numbers for drug B on your worksheet. And if I go too quick, I apologize, but you know what? I will send you an answer sheet for all of this, okay? All right. Did you get the same results? Okay.
Yeah.
Good, so let's move to the next step, which is to calculate the probabilities of each pathway occurring. And that's really simple. All it is the probabilities multiplied to each other. And in this case, the topmost pathway, we call it pathway 1. The probability of that occurring, a cure without adverse events in drug A is 0.56 or 56%. You could think of it as, let's say 100 people take drug A, we would expect 56 of them to have a cure without side effects or without adverse events. And we do the same thing for pathway 2, 0.14, and so on. And here's the key thing to remember. We sum up those probabilities, we add them up for each drug, okay? And it should equal to 1. And this is a good check for your accuracy. If it does not equal to 1, then there's probably a data entry error or some kind of calculation problem. All right, so go ahead and finish it for drug B.
It's 1.
Yeah, good. So you all have, I hope we all have the same numbers. Let me know if I'm wrong. That would be embarrassing, but I think this is correct here. And it should add up to 1. No difficult math so far, right? So no advanced calculus or anything. Now we will work out the path costs associated with each of these pathways. So for drug A, a cure without adverse events would cost how much? $100. Okay. I know this is in dollars. I was going to convert everything to rupees, but I got a little overwhelmed. I wasn't sure what, anyway, so bear with me. So $100 for the cost of drug A cure without side effects. Now, what about the second pathway? What if you have a cure with a side effect? How much would that cost? So we have the cost of the drug plus, plus the cost of treating an adverse event. Maybe it requires more medication or an office visit. So there's an additional cost. And that's $125. Now, what about a treatment failure on drug A without side effects? So we have the cost of the drug, the cost of the treatment failure, plus the cost to treat the adverse, I'm sorry, there's no adverse event there. So it's just $300. And of course, the last pathway would include all of 3 of those costs for drug A. The medication, the failure, and the adverse event, $325. Okay, I'll give you a few more, give you half a minute to finish for drug B.
Audience can unmute and say, oh, it's done.
I'm just guessing. I don't really expect people to answer. But if I do go too fast, go ahead and just copy these down. You get the idea. I hope that makes sense. Okay. All right, good. So the next step now is to work out the expected costs for each of these pathways. And that's simply the path probability times the path cost. So the expected cost for first pathway, drug A with a cure without side effects, is $56. 100 times 0.56, $56. We're just multiplying those two. So 0.14 times 125 gives you $17.50. Okay, and so on. And this is where you probably need a calculator. I can't do that in my head. Now, the last part of this is to sum up those costs, add them all up, and that is your average cost for drug A. That's the average cost. So the average cost for each patient is $165 to receive drug A. Even though the cost of drug A is just taking it is $100. But when you calculate the probabilities and the costs associated with treatment failure and adverse events and dealing with those, the average cost is $165 per person for drug A. Go ahead and try out a couple. You don't have to do them all. Try out a couple for drug B.
$56, so it's 120, then 15, then -3, something such as that was and it is 3.75. So it's 125 plus 40, 160 plus 15, 175, around 172, right? Right.
Yes. Okay. Good. We're on the same page. Excellent. Thank you. All right. So it's interpreted the same way. The average cost of drug B is 172.50, even though the cost of taking it is $150. Again, we're including the probabilities of adverse events, the cost of dealing with those. All of those things are rolled into that one number. So we have our two average costs. The next part, we have to figure out, again, how did we define treatment success in this model? It's a cure without side effects. So we look at the 0.56 there for drug A and the 0.81 for drug B. And before we do any further analysis, you can already start to see that, ooh, drug B cost more and is more effective. Okay, cost more, more effective. So it could be a trade-off. It is a trade-off, but we'll continue. So now let's calculate the results of this analysis, and then we'll interpret those results. Now you could calculate the cost effectiveness ratio for drug A, which is the total expected cost divided by the probability of success. So 165 divided by 0.56 is 294.64 per cure without adverse events. So go ahead and compute the cost effectiveness ratio for drug B. So 172.50 divided by 0.81.
Divided by 121. It's
Yeah.
nearly 1.
Do we get that together? Okay, 212.96, 212.96. So these are useless. These numbers are totally useless. Why? What are they comparing to? 294.64 compared drug A to nothing. And this ratio for drug B is drug B compared to nothing. So why did I ask you to do this? Because results of many cost effectiveness analyses might include these numbers in the results, and they're useless because they're not comparing to each other. You're not comparing A to B. You cannot do that with these numbers. These numbers are A versus nothing and B versus nothing. And software programs like Triage, which we use to do decision modeling, will spit out results like this. But again, this doesn't tell you anything. So forget that. If you see it, cross it out. It doesn't mean anything. What is really important, there is a way to distill all of this information into a single numeric value called the incremental cost effectiveness ratio, or ICER. And that is the difference in costs divided by the difference in effect. So it's based on these four numbers. So you go ahead, calculate that ratio, and I'll give you a few seconds to do that. Did you get $30? So we interpret that as $30 per additional cure without adverse events. So drug B costs $30 more per additional cure without adverse events. Sometimes I'm asked, well, can you do A minus B divided by A minus B. Yeah, you can do that as long as the numerator and the denominator are consistent. But generally, we put the next best alternative first, minus the standard of care or what comes before it. Well, congratulations. You just completed your first decision, maybe some of you completed your first decision model. But how do we interpret that? That ICER as a number by itself is not that useful. We'll talk about that. But there's a nicer way to interpret this, and we'll do that by looking at a graph. So here's our two drugs, A and B, and these numbers should look familiar to you. We use those to compute the ICER. And remember, the ICER stands for incremental cost effectiveness ratio. So the difference in effect, drug B has an incremental increase in effect of 0.25 and an incremental increase in effect of $7.50. Now we can take this same information and change the origins of the graph to go on drug A like this. I didn't change any information. I just moved the origin of the graph from this to this. It's the same information, but now we have what's called a cost effectiveness plane. And that gives us 4 quadrants, and each one has an important meaning. The top half of the graph, anything in the top half means it costs more than standard of care. Anything to the right is more effective than standard of care. And so we get a northeast, southeast, southwest, and northwest quadrant. Now, if B cost more and was less effective, so if B cost more and was less effective, which quadrant would it be in? So it would be in the northwest quadrant, and we would call that dominated. Now, which quadrant would be in if it cost less and was more effective? Cost less, more effective. Which quadrant? So that would be the southeast, right? So B would dominate A. We would not have to do any further analysis. B is better than A, or if it was the northwest quadrant, B is worse than A, so we don't need to think about it. It just drops from our analysis. But most of our time in pharmacoeconomic analyses are spent here in the northeast quadrant, where there's a trade-off, more costly, more effective. And so each quadrant has different implications. So then the question becomes, is B cost effective? It's a trade-off. Clearly, if it was in the southeast quadrant, that's cost effective. But it's here. So is that cost effective? Is it worth it? Is the extra cost worth the extra benefit? So you make these calculations all the time, thinking about what kind of internet service you want. Cost more benefit. And so the important thing here is, what are you willing to pay? WTP, willingness to pay. Are you willing to pay for more benefit? So the thing is, you can take this information, give it to different decision makers, and they will each come back with a different decision. It's the same information. So back to our example, you can draw a willingness to pay line called a threshold on the graph. And that indicates, and that line can be in different places. And anything above that line is not cost effective. Anything below that threshold is considered cost effective. And that line can change from decision maker to decision maker. But again, we only care about this when we have something in the trade-off regions, because anything in the northwest or southeast is automatic reject, or accept. So we're only talking about those trade-off areas. Now, as an extreme example, what would happen if your willingness to pay line was completely flat, straight, horizontal? What does that mean? Well, that would mean a decision maker, that's called a minimum threshold. A decision maker is not willing to pay a single rupee more for any increase in effect. Even if it's the most effective thing out there, 1 penny more, 1 rupee more, no, not cost effective. So I'm just illustrating this as an extreme example. What if the willingness to pay line was completely vertical? What would that mean? It's called a maximum threshold. In this case, a decision maker would be willing to pay anything for even the smallest increase in effect. I think, yeah, I think industry might like that example. So the willingness to pay depends on the decision maker. And really, the willingness to pay line could be a gray area. Maybe decision makers don't know what their willingness to pay is. And if they do, they're certainly not going to tell some of us. So it could be a range. And also, the other thing to make things it's a little more complicated is that A and B are really just point estimates that represent more variation. There's actually ranges associated with each of those point estimates. And now we get into an area where there's another graph called a cost effectiveness acceptability curve, or CEAC. And it can handle this kind of variation much better, but we'll save that for another talk. So back to our example, we have our ICER, and it's $30 more per additional cure without adverse events than drug A. And we could represent that ICER by a line from A to B. Now, things get really interesting, and this is where decision modeling really shines, is when you have 3 or more treatments. What if you have drug C, D, E, F, and G? Then what do? Do you compute the ICER between A and C or between B and C? Because an ICER can only compare 2 things at once, right? So what do you do when you have 3 drugs or 4 or 5? And again, not just drugs, it could be any healthcare technology. Well, there are at least three different scenarios. In this first scenario, in this first scenario, we have A, B, and C. And I want you to just imagine if you were to redraw the origin of the graph on B, where is C relative to B? Right? So C dominates B. It's more effective and less costly than B. So in this scenario, when we have 3 drugs, B simply drops out from our analysis. We don't need to include it anymore. It's dominated by C. B is not the next best alternative after A. C is. And we just simply compute the ICER for A to C. And I'll show you in a few moments how you could look at a table of numbers and make that determination very quickly. This is really useful when you have a dozen or 2 dozen different technologies that you're comparing, and you can quickly just take out the ones that are not relevant anymore because they're dominated. And then you can narrow your analysis to a more manageable handful of comparators. Now there's a second scenario. We have A, B, and C. C is in a slightly different location here. In this case, we would compute the ICER for A to B and then B to C. But note that most of the effect for drug C is actually achieved by drug B and at a lower cost. And the So C is more effective, but it's a lot more costly than B. Now, if your willingness to pay line includes C underneath it, then you can afford maybe a combination of B and C, and certainly you could afford C. If your willingness to pay line goes underneath C but over B, then you'll see it's just not an option for you. Now there's a third scenario, and before I get to that, you could mathematically compute A to C ICER, but in this case you would not do that because it's misleading. It suggests that there is no option B. Option B doesn't exist. It's just a very misleading thing to do. There's no reason to compute that. Now here's a third scenario, and this is an example from the literature, a timely one. These authors looked at influenza vaccines for US senior citizens who are over the age of 65. And they looked at no vaccine compared to trivalent and to quadrivalent and high dose trivalent vaccines. And they have this table, and they sorted the table by, it's in QALYs, so it's not successfully treated patients. It's another metric called QALYs, and they sorted it. You can either sort the costs or the QALYs, it doesn't matter, or the effects. And they sorted this from ascending from lowest to highest. And a QALY is a quality adjusted life year. It's a very common metric in cost effectiveness analyses. And that's the quality of life times the quantity of life. So if the quality of life ranges from 0 to 1, 0 being death and 1 being perfect health, let's say 0.60, it's not so great, but let's say the medication or some kind of technology increases your life by 8 years, your QALY would be 4.8. Okay, so that's a QALY. In any event, looking again, do you notice something strange about these costs? Look at the difference between quadrivalent and high dose trivalent. Do you see it? Let's redraw the origin of the graph on high dose. Now, do you see it? How does high dose compare to quadrivalent? Quadrivalent is dominated by high dose. So we can drop that one from our analysis. Now we only have to focus on 3 of these vaccines. Well, no vaccine. Okay, so we can draw the ICER or compute the ICER for no vaccine to trivalent, and from trivalent to high dose trivalent. Now here's the third scenario. If you compute the ICER for high dose trivalent to no vaccine, it comes out a lot less than the ICER for trivalent. So it's 8,833 compared to 11,331. So this ICER is actually lower than this one. So that's called extended dominated. And that's kind of hard to see until you can compute the ICERs. Another way to think about that is if your willingness to pay was only $10,000 per additional quality adjusted life year, then trivalent would not be cost effective and high dose trivalent would be. Regardless of your willingness to pay, even if your willingness to pay was $1 million, high dose is always going to be a better value than trivalent in this model. Okay, so that's called extended dominated. Now, we're coming to the end here, and I want to build on this idea of a decision tree and help you or show you how you can take it to the next level. And this is called a Markov model. And you might see, this looks like a normal tree, right? Just like what we did with the square and the circle nodes and the terminus triangle. But at the end, this one has M's, little M's and circles. That stands for Markov model. And the really cool thing about Markov models is, and this is a better example of one, it's a bubble diagram. And people can go back and forth between health states. So it's great for chronic or long-term chronic conditions where people can go from like mild ulcerative colitis to moderate to severe, back to mild over time, maybe remission. So anything with disease staging that has long-term effects, that you can model over 5 years, 20 years, is great for Markov models. And let's say we do a 20-year model. The other thing that's great about Markovs is that you can capture the element of time. So imagine 100 people starting off in this functioning graft stage. Let's say it's a 20-year timeline or 20-year time horizon for this model. And we'll say that people cycle every year, one time every year for 20 years. So in this first year, everyone's here at 100. And then maybe in the second year, some people stay here. There's this recursive arrow. Some people go. There's probabilities of going to here or probabilities of going to another health state. And then you run it again, another cycle and another cycle. And after 20 years, you can keep track of who went where and what the costs associated with each health state. You have the probabilities associated with all that. So you can capture time and you can capture these back and forth transitions between health states. So that would be the next level of decision modeling. That takes it to another level. And you will see that quite a bit. It's a little bit, well, it's a lot more complicated, but it's really neat. And that's decision modeling in a nutshell. If you're hungering for more information about health outcomes and pharmacoeconomic research, we do have a training program that's live coming up in October in Arizona. And we also offer online training programs as well. So if there's maybe a couple questions, I can take some questions or comments, or we can do that offline. I can give you a little bit more time to get to your next seminar. But in the meantime, thank you so much for your attention and this opportunity to share this really cool kind of analysis that cuts across so many different disciplines and is very useful for distilling large amounts of information down into some kind of actionable decision-making tool that you can use.
Yeah, Jason will definitely take 1 or 2 questions, please.
Sure.
It's amazing session. Prita, please. Yeah.
Yes, sir. Thank you so much, sir. It was really innovative and we really learned a lot. Now taking questions. So we have a couple of questions in the chat box. I'm going to read it out for you.
Okay, thank you.
So the first question goes like, can we use this model for pandemics, like what we are facing right now?
Yeah, well, you can use it for comparing treatment alternatives. And so you can use it to compare programs or policies. It may be hard to get all of the accurate costs and all of the data elements that you need, but maybe with a little bit more specific information, we could decide, we could talk about what you can and can't do. But overall, if you're comparing programs or technologies, you could certainly use this. One thing to note with the vaccine models is it's hard to estimate herd effects. So, and you have to have sufficient data for every pathway in your model. And sometimes you don't. There's nothing in the literature or it's a new treatment. So sometimes the best you can do is have expert opinion, and that's okay. For maybe one data element, you get expert opinion, and as long as you're transparent about that in your write-up, and you can justify it. That's okay. People do that.
Okay. So there is another question which goes like, what is an average cut cost for a new drug if we are using pharmacoeconomics?
Okay, so for a new drug, right, it hasn't been around. It's, you know, coming to the market, and you just have to, the manufacturer would have to just set a price, and manufacturers do this before drugs come to the market, to analyze how they fare in comparison, because they can't control all of the effects, right, and the adverse events and all of those things, but they can control how they price the drug. And that could definitely tip the favor of some drugs. If your analysis favors drug B, but you lower the cost of drug A, maybe now your analysis will favor drug A. And that's called a sensitivity analysis. And that's where we used only one single estimates for all of the branches, but what if you used a high and a low? A high cost and a low cost. And you could do this for your probabilities too. Maybe your probability isn't 80%, maybe it's ranges from 70 to 90. You can plug these different values into your model and see how it changes all of your results, how it changes the ICER. But yeah, getting the costs is tricky. In the United States, there's a lot of different published costs, but we never truly know what decision makers are paying for their other, you know, like standard of care, for example. So we just justify, you know, here's where we got the information from, and you can plug in your own costs if you have it.
Okay. We have another question, sir.
Mm-hmm.
If API cost is same for all company, then how cost is varying in product of the same medicine?
I'm sorry, can you repeat the question?
Yes, sir. If the API cost is same for all the companies, then how is the cost varying in the product of the same medicine?
Oh, okay. This comes up in when we look at generics. We can compare you know, different drugs. Maybe they cost the same. They might have slightly different outcomes. So even though a drug might cost the same, if the outcomes differ, then that will change the ICER and the analysis. But let's assume that we have 3 or 4 different things that are all the same cost, all the same effect. Then what do you do? Well, that's a different analysis. That's what we call a cost minimization analysis. So that assumes that the effects are all the same, the costs of the drugs are all the same, but can we do anything to reduce the cost of, say, administration? Are there rebates or discounts available? If 3 or 4 different treatment options are the same cost and same effectiveness, then why not include all 3 or 4 of them and let patients decide, or physicians can decide which one they prefer to use for whatever reason. In the United States, a healthcare plan has what they call tiers for formulary for different levels for which medication they will provide at the biggest discount to patients, or how much patients have to pay for different different alternatives. But if all the alternatives are the same, why not just let everyone decide which one to use? So that's a cost minimization analysis. We don't do too many. You don't see too many of those types of analyses.